That concludes the the plenary presentation. So now let's open up the floor for, let's say, 10 or 15 minutes for questions, comments, observations, anything else you want to share with us. I must commend the group in this room. Nobody has left. It's really, it's pretty good. I can see that from here with the door. So please, the floor is open. Who would like to take the floor first? Nobody?
Maybe I have a question.
Yes, please, Estelle.
I have a question for you all. How many of you were at the PMAC conference in January? Okay.
Yeah.
So there are people that are
good.
that are aware.
While people are thinking of a question, I wanted to address a little bit Teresa's question about faculty development. And although the issue needs to be studied a great deal more, some promising practices that we've seen in Kenya, they've done a real good job of using adjunct faculty. These include master clinicians who are actually in the Kenyan Ministry of Health practicing, and they actually get credit for their career advancement by teaching in the schools. And this is a win-win. As Rebecca said, one of the challenges is some of the people teaching haven't laid hands on a patient in decades. And how is that right if you're teaching clinical skills? And so it not only increases the number of professors, but I think increases the relevance of the teaching by having these adjunct faculties. I think another promising practice, once again, needs to be better studied is schools need to create their own faculty. Every year they need to identify the top students that they want to continue on and get on a faculty career track, whatever that might mean. But faculty don't happen by accident. They have to be grown and groomed. So those are two top practices that I could recommend. A third would be sharing of faculty. Certainly you probably need, a nursing faculty in every country, but for, creating policy professors or epidemiologists, you might not necessarily need a full faculty in each country, and so there can be regional sharing of that type of faculty through improved e-learning or through teaching of modules. We see now a lot of people maybe going in country, whether from elsewhere, in the region or from further abroad, going in country for a couple of months to teach a module and then going back home. And that can be a very effective way of teaching and getting around the faculty shortage.
Thank you very much, Kate. Akiko? Maybe say who you are, Akiko.
Thank you. My name is Akiko Maeda from the World Bank. I'm leading the work on human resources for health. Thank you very much. Erica mentioned that she's reaching out to UNESCO now and starting to work together, but one of the biggest challenges we face is the silo segmentation between the education and health professionals, even within the agency. So I'd like to know, what is USAID doing? I'm not familiar with USAID's education strategy, and how are you working with your folks? Because within the World Bank, we have a very large education program, which is much bigger than actually the health program, and they include work on vocational training, accreditation, higher education, and transition from school to work. So these are critical areas that are very relevant. They haven't looked specifically at health area, but this is a potential that we're reaching out. So that's mainly my question. Thank you.
Perhaps we'll collect one or two more questions before we go back to the panel. Yes, please. And maybe you could also introduce again yourself.
Sure. I'm Bill Burdick from FAMER, Foundation for Advancement of International Medical Education and Research. I think there are two structural issues that Erica referred to and that you've referred to. One is the issue of accreditation as a constraint or as a promoter of growth. Many of the faculty issues are constrained by accreditation issues. We've done some of the work that World Bank has funded in Indonesia and Vietnam, and we're working with the World Federation of Medical Education to try to recognize good accreditation systems. So accreditation systems can drive good stuff, and they can prevent good stuff from happening if they're not done well. The other piece is something that Erica mentioned, and that is that so many of the solutions are local. And so what we've done through FAMER is to encourage faculty members in our programs to come up with authentic projects. But the other thing that we've done is to sponsor a competition, projects that work. So we look for projects all around the world where people are doing good things in education that can change health outcomes, and then we sponsor those folks to come to an international meeting.
Wonderful. Thank you very much, Bill. Any comments perhaps on these two issues from any of the panel members?
On the question that Akiko asked?
Yeah, for example, please.
I have to say that maybe some of my other colleagues here are more aware of work that we've done with the folks that work on higher education, but we haven't really crossed that hall. I think that we need to do that more. A lot of the work that Usaid does in education is related to setting up different twinning and sharing programs. And there's been a number of projects that have focused on higher education, but not so much in the area of health, because we're always told, oh, you guys in health have so much money, that in education, we're not going to address education related to health professional education. So nonetheless, there are probably skills and lessons learned there that we need to find out about.
So in response to Akiko, I agree we have to involve our friends in the Ministry of Education. And in fact, actually, I did extend the invitation to our friends in the World Bank on the education side. CapacityPlus has also produced a brief on transitions to education. It's called Bridges to Education, of how we can increase the number of graduates going into employment. You often see a fall off between the number of people who graduate versus the number of people who are employed in field. And there are a number of very easy mechanisms to increase that percentage, and we have that brief on our website. And in regards to what Bill said about accreditation of schools, I can't agree more. You know, there's some accreditation procedures which are just so out of whack with the reality on the ground in the country that they really are preventing schools from training adequate numbers. So it's definitely something that needs to be looked at. Yeah.
Any other observations, questions? Yes, please. Go ahead, Marilyn.
Marilyn DeLuca, Global Health Systems and Philanthropy. Thank you for the presentation, Rebecca. I especially appreciated your presentation. I wonder if you could describe what CapacityPlus is doing with the findings from these studies in terms of really getting them integrated within country-level plans and systems and communication back to governance, ministries of education, finance.
Should I go ahead?
Please.
Yeah, from the beginning, the examples in DRC and Ethiopia working together with the Nursing Education Partnership Initiative. In Nigeria, we start working with the governments and looking at what would the assessment look like, what should be included in the assessment, and how would the results be used. So there have only been a few schools where they've asked us to come in and just look specifically at that school, and there we've, for example, the one in Ghana, we just addressed those things that school had control over. But that's why I said if there are several schools that we can work together at the same time, the NEPI has their steering committee where we're bringing together representatives of the Ministry of Health, Ministry of Education, councils, nursing and midwifery councils, et cetera, so that we can, when it's time to make some of those bigger changes, we have those people already on board.
Thank you very much, Rebecca. Maybe I'll use the opportunity I have to put a word of my own in. I think I'd like to address actually the U.S. government in this respect. I think the U.S. government obviously is absolutely leading in global health worldwide. If you look at all the countries in the world, the U.S. is clearly at the center of it. As you said, the U.S. hasn't really made strongly the link between health and higher education. In higher education, in terms of engaging education on the medical side, you have to go through universities. So it's basically matching the two worlds of the universities and the global health issues, not only at USAID, but across the board, including accreditation institutions, Look, the United States and Canada clearly at the same time are also very much leading at accreditation. One of the big weak spots in accreditation around the world is in the Francophone countries, including previous Francophone countries. You mentioned Vietnam. It's clearly extremely weak on accreditation, Laos, some of the Pacific Islands, Cambodia, and all of West and Central Africa. So support from the US in terms of a leadership, not only internally with vis-a-vis USAID, but with regard to UNESCO, with regard to the higher education group in UNESCO, with regard to WHO, with regard to other donor agencies, the Health Leadership Group, the H8, et cetera, to bring together ministers of education and ministers of health, I think is an opportunity that actually sits very well these days. And it sits especially well since education, increasingly, if one looks at medical schools, a lot of what's being said is still addressed in a vertical fashion. I leave aside for the moment that the clinical profession doesn't buy into a lot of what we've done, right? The clinical profession quite often sits back and says, look, there's a power game here. I'm not giving up my power here. As chairman of, for example, internal medicine or oncology, you can do whatever you want in global health, but this is my apartment, I have the power, I have the money. So how to engage these people? But that's kind of a vertical element. Education, including medical education and health education, increasingly is not a vertical issue, it's a horizontal issue. So you need the engineers, bioengineering, you do biochemical stuff, you need transport in terms of the health challenges, etc. So that whole world is increasingly coming together for the next 5 or 10 years, that countries as such see this as a challenge. And an element that plays a main role that hasn't been mentioned this morning is research. If you want to talk about high quality medical education or nursing education or outreach, health worker, community education, you have to link it up with research. And research often doesn't sit anymore in ministries of education. It sits in ministries of science and technology and research, including their budgets. So it's much more of an overall engagement of, let's say, the US or the European Union, etc., with all these big players vis-a-vis the future of global health across the sectors that will ultimately deliver the project, I would think. Any other observations, questions? Yes, please. If you could introduce yourself for a moment.
Zorae Taleb from George Washington University and the Coordinating Center for MEPI. Two somewhat unrelated questions or comments. One is related to staff development, faculty development. And from our work with Zambia through MEPI, we've seen that for decades they had been investing in sponsoring faculty to go through graduate training to become faculty. But in many cases, there were no graduate degrees offered in Zambia. So they would go abroad to do training in anatomy or histology. And so what they did with MEPI is to use the funding to start master's degree programs in those training, hoping that the retention rate of those faculty will be greater. So I'm wondering if there are any other broader efforts to encourage both universities or funding to go into starting and initiating locally relevant and sort of nested faculty training programs, master's programs, PhDs, et cetera. So that's one question. And the other question, unrelated, Dr. Wheeler and others had mentioned leadership training, excuse me, for health professionals. And there was also mention about connecting with UNESCO and MSF. We've seen through MEPI that the definition of leadership is quite broad. Some will limit that to talking about population health, others talk about management. So is there a consensus or a dialogue going on about what does leadership, what does it constitute in the context of health professions education?
Thank you very much. Maybe a last response before we then go to the, we have one more in the back there, since many had been to the left. Maybe you can ask your question now, and then we'll finalize the answer.
Just very quickly, David Wofford, Meridian Group International. Curious about there's the nurses and high-level, the doctors, but at the bottom end, the community health worker, extension workers, and those lower level that are out in the rural areas. How do you see the difference between dealing with them in the kinds of structures? Because it may not be institutional kinds of training, but there may be other structures. So I'm very interested in knowing how you see medical education or professional development at that level.
So the two issues of the leadership and the question of the lower level cadres.
Yeah, on the community health workers and the frontline cadres, we certainly think it's very important to give them a professional educational home and to standardize it as much as possible within country. So, in fact, CapacityPlus has an initiative of the professionalization of under-recognized cadres. So we certainly would, depending on the country context, encourage community health worker training to occur actually at a school that they can have a lifelong relationship with. Regarding Zore's question about, sort of regional, training, I know the Caribbean does a lot of regional training of some of these cadres that you don't need as many of, and I think the West African Science Campus. I don't know. Do you know a little bit more about that?
Yeah,
That's another effort to do this regional training.
Yeah, partly it responds to both questions on the leadership and on the lower level cadres. I think the recognition in some parts of the world, for example in West Africa in the context of ECOWAS and in the West African College of Physicians and Surgeons, is clearly the point you were saying. They see that many of their graduates actually leave because the opportunity is not there to continue for even, let's say, basic MDG-related specializations like obstetrics and gynecology, pediatric surgery, and so on. So they've created deliberately a program to retain people like that. It has the effect that subsequently the leadership strengthens very significantly. The moment you have a recognized pediatric subgroup in West Africa and playing a bigger role in the West African College, the leadership goes up, including for, let's say, pediatric or obstetric leadership for the lower level cadres. So if one looks, for example, in really poor countries like Liberia or Sierra Leone or Togo or the poorer parts of Nigeria, some of the states, like Kwara State, for example, you see an effort to have the residents in the specialization programs no longer trained in the central teaching hospital, but to rotate them through pretty remote clinical teaching facilities where they engage explicitly in team learning and team teaching with, for example, outreach workers and nurse assistants and so on and so forth.